Welcome to this session where we'll be talking about normal pregnancy, the physiology, antenatal care, traditional and the focused. We'll also be talking about risk assessment in normal pregnancy. I am Dr. Adeniyi Fashanu. I'm a senior lecturer at the Ladoke Akintola University of Technology, Ogbomoso, and I'm also a honorary consultant, obstetrician, gynecologist to the Lautech Teaching Hospital in Osogbo. During this lecture, we'll be talking about physiological changes that take place in pregnancy. We'll be describing the objectives of antenatal care. We'll also be discussing the different models of antenatal care. We'll describe the activities that take place during routine antenatal care. We'll also be detailing essential diagnostic workup during antenatal care. We would outline antenatal care fetal well-being assessment strategies. We'll also be discussing various health interventions during antenatal care. We will be talking about identification of high-risk pregnancy. The learning expectations are, at the end of this lecture, the participants should be able to understand physiological changes that occur in pregnancy and also to be able to discuss antenatal care, also identify risky conditions in pregnancy for prompt intervention. And at the end of this lecture, you are also expected to be able to answer few questions on the topic that we have discussed today. We cannot be talking about pregnancy without discussing the hormones of pregnancy. And this is very important for several reasons. Number one is that the hormones help in maintaining pregnancy. The hormones also prepares the pregnant woman and the birth canal for delivery, and also help in preparing for breastfeeding. In pregnancy, there are three major hormones. The first one is the beta-HCG, the second one is the estrogen, and the third one is the progesterone. The beta-HCG peaks just before 3 months, and it is largely produced by the placenta. Estrogen initially is produced by the corpus luteum of the ovary, and later it is essentially being produced by the placenta. The level of estrogen increases as pregnancy also increases, and it helps to prepare for delivery throughout pregnancy by increasing the number of oxytocin receptors. Progesterone also initially is being produced by the corpus luteum of the ovary, and later on it is also being produced by the placenta. It also rises continually throughout pregnancy as well. However, just before delivery, both estrogen and progesterone levels drop, allowing for the onset of labor. Progesterone also works as a smooth muscle relaxant and helps in maintaining the uterine lining. The physiological changes that occur in pregnancy relate to one, the hormonal changes that take place in pregnancy. It also relates to the changes in anatomical structure of the uterus as the uterus enlarges and fills the abdomen. It also relates to the changes that take place in the growing fetus. I will be talking about the various changes that we have, in the various systems of the body, and we'll be starting with the respiratory system. In the respiratory system, we have an increase in pulmonary blood flow, which may actually cause hyperventilation. The tidal volume also increases by about 30 to 40%. The inspiratory capacity increases by about 5%. The vital capacity and inspiratory reserve remains essentially the same. The total lung capacity, however, reduces by about 5%, and we have an increase in minute ventilation by about 30 to 40%. Because of these changes, the pregnant woman is at risk of developing respiratory alkalosis from dyspnea, hyperventilation, and reduced exercise tolerance. What are the changes that take place in the cardiovascular system? In the cardiovascular system, we have an increase in cardiac output, which is a product of increase in heart rate and the increase in stroke volume. This causes a decrease in systemic vascular resistance. And we also have a decrease in blood pressure in normal pregnancy. However, when we have a raised blood pressure in pregnancy, it should raise the suspicion of preeclampsia. We have reduced peripheral vascular resistance, and there is a reduced arterial blood pressure in the first 24 weeks of pregnancy. But after this period, it gradually returns to normal by the time the woman is at term. In the hematological system, we have an increased plasma volume, which occurs from as early as 6th week, and it peaks at about 30 to 34 weeks. The mean increase is about 50%, and this increase in plasma volume is greater in women with multiple pregnancy, that is, women with twin gestation, triplet, and all that, and it also contributes largely to the development of edema that some of these women experience in pregnancy. There is also an increase in red blood cell volume by about 25%. The greater increase in plasma volume compared to increase in red blood cell volume causes anemia in pregnancy. In pregnancy also, we have increased clotting factors causing a hypercoagulability state, which may lead to development of deep venous thrombosis in pregnancy. Particularly, we have increase in some clotting factors: factor 7, factor 8, factor 9, and factor 10. These are elevated in pregnancy, and the elevation may actually predispose some of these pregnant women to development of deep vein thrombosis in pregnancy. However, factor 2, factor 5, and factor 12 do not increase during normal pregnancy. And also the bleeding time and clotting time also essentially remain normal throughout pregnancy period. In the musculoskeletal system, there is an increase in body mass index with an average of about 11 to 12 kilogram weight gain throughout the entire pregnancy period. We also have development of stretch marks on the abdomen, and most of these women experience low back pain from lordosis and abdominal protrusion. There could also be development of carpal tunnel syndrome. They can have sciatica, and also you can have development of muscle cramps too. These are some of the physiological changes that occur in the musculoskeletal system. The endocrine system, there is an increase in anterior pituitary gland hormone secretion. We actually have hypertrophy of the anterior pituitary gland, and this is because of an increase in the hormones that we talked about earlier, the estrogen, progesterone, beta-HCG. And some of these women may also be predisposed to development of gestational diabetes, and there could also be an increase in thyroid hormone secretion and development of goiter. These are some of the changes that can occur in the endocrine system. Dermatological changes include increased skin pigmentation from increased production of melanin in pregnancy. There may also be distension and proliferation of some blood vessels. There could be facial flushing, and we have the presence of striae gravidarum, which is also present in pregnant women. And it is particularly very noticeable in light-skinned women, but it's just a thin line that arises from around the pubic symphysis, and it goes up even as the pregnant, as the uterus enlarges towards the epigastric region. In the gynecological system, the changes that we experience, that women experience, is majorly due to estrogen and progesterone increase that take place in pregnancy. And this includes breast enlargement, areolar pigmentation. There is also uterine hypertrophy and stretching, which could even be as much as up to about 10 times the pre-pregnancy state. There could be cervical gland hypertrophy with thick mucus plug from increased estrogen production. Vaginal lactobacilli proliferation from increased estrogen also leads to increase in the production of lactic acid, which causes a decrease in the pH, which is actually protective, creating a non-favorable environment for other pathogenic organisms during pregnancy. In the breast, what do we have? Because of the effect of estrogen, we have increase in the production of adipose tissue, and we have increased lactiferous duct system, preparing the breast for lactation. The effect of progesterone also causes enlargement of breast lobules with proliferation of myoepithelium, also leading to lactation. And this is why we have breast enlargement, that starts taking place in pregnancy, in preparation for lactation by the time the woman has delivered. In the renal system, the kidneys enlarge by about 1 centimeter. We also have dilatation of the renal pelvis, the ureters, and this takes place essentially from smooth muscle relaxing effect of progesterone. We said earlier that in pregnancy, you have increase in the production of progesterone, and progesterone helps in relaxing the smooth muscles. Now also we have a raised residual urine volume. That is an increase in renal plasma flow. We have a raised glomerular filtration rate, and the creatinine clearance is also markedly elevated in pregnancy. We have reduced plasma osmolality, that is a raised plasma renin angiotensin. But in whole, the 24-hour urinary protein excretion is unchanged, and that is why presence of protein in the urine in a pregnant woman may connote a serious medical condition in pregnancy, because protein excretion should remain unchanged throughout pregnancy. And because of the increase in the renal plasma flow, we have a lot of our women having several urges to urinate. So you have increased urinary frequency also taking place in pregnancy. In the gastrointestinal system, what do we have? Because of the smooth muscle relaxing effect of progesterone too, we have esophageal relaxation, which may cause reflux, which is a a common complaint during pregnancy. You see a lot of women coming to say they have heartburns, they have discomfort in the upper abdomen and all that. That's because of the reflux that takes place from the effect of progesterone on the smooth muscles of the esophagus. We may have increased intra-abdominal pressure, which worsens the reflux and may actually cause development of hemorrhoids. It's also a common thing in pregnancy. You have a lot of women complaining about piles in pregnancy, and that's because of the increased intra-abdominal pressure that take place in pregnancy. We have reduced bowel motility, also from the smooth muscle relaxing effect of progesterone causing constipation. And that is why I said that there is no way we can be talking about physiological changes in pregnancy and we will not talk about the hormones that actually bring about these physiological changes in pregnancy, particularly estrogen, progesterone, and the beta HCG. These are all hormones that play important roles, during pregnancy. Now, what is antenatal care? Antenatal care is the professional care that is provided to a woman and her partner to support them and their baby through the pathway of pregnancy, and also to help achieve the best possible health, psychological, and social outcomes for the mother, baby, and the family. It may also be described as periodic and regular supervision, including examination and advice given to a woman during pregnancy. The supervision should be regular, periodic in nature, and in accordance with the need of the individual. HACOG defines, that's American College of Obstetricians and Gynecologists, define antenatal care as the care given by a healthcare provider or any health practitioner to all pregnant women to ensure the best health conditions for the women and their fetuses during pregnancy. It is basically a screening program intended to detect complications early, provide health education, and implement effective promotive and preventive health interventions. What are the basic components? There are 4 basic components. Number 1, we want to identify risk and risky medical conditions in pregnancy. We want to prevent and manage pregnancy-specific or concomitant diseases. We also want to educate these pregnant women. The education involves so many things. We want to talk to them about pregnancy, about the things to expect in pregnancy. We want to talk to them also about family planning. We want to talk about even the care of the care of the children even when they are born. And the 4th component is health promotion. We want to promote good health behavior, good health behaviors, and even to also promote adequate social functions that will not impede on their general care, general health during pregnancy. The objectives. The major objective of antenatal care essentially is to reduce maternal and perinatal morbidity and mortality. Also, we also want to timely detect and manage complications. We want to ensure the birth of a healthy child. And we also want to ensure that even the mother giving birth to the baby is also healthy during the pregnancy and even during delivery and even thereafter. One of the objectives is also to provide essential health education to the mother, including information on the danger signs of pregnancy. So these are the major objectives of a routine antenatal care. Now we have models of antenatal care. We have traditional antenatal care models, which began over 200 years ago. And these include instituted programs and interventions that were traditionally thought to benefit both the mother and her fetus. Activities as at that time were not scientifically tested as to the effectiveness of their benefits. And this include a visit pattern of 4 weeks from the time of booking, 4 weeks until 28 weeks, Then the woman will now be seen every 2 weeks until 36 weeks, then weekly until the woman delivers, with many interventions taking place during each antenatal visit. And this has been found to lead to up to like 14 visits, and with a lot of cost incurred for many investigations that were not necessarily warranted. And also, most of the time when these women come for clinic, most of them do not even have any specific complaints. They just come because they have been told to come back for a routine antenatal care clinic. So a lot of cost is being expended on this type of antenatal care model. However, recently it's been suggested that this traditional antenatal care practice should be replaced by new models of focused antenatal care programs. The new model is also called, the focused antenatal care is also called the new or the WHO models. And these models actually followed large, randomized, multi-center trials between the traditional and focused antenatal care programs that identified evidence-based interventions and visit patterns that benefited mothers and their fetus. And they have also been found to be cost-effective as well. The new model suggested 4 routine visits only throughout pregnancy at different gestations, with a view of evidence-based diagnostic and intervention modalities performed at each visit. And these visits were scheduled to take place as the first one at about 16 weeks, the second one at about 28 weeks, 32 weeks, and lastly at about 36 weeks, when birth preparedness is actually talked about. However, there could be additional visits incorporated based on individual basis. Some women may actually need to be seen more frequently, probably because they are high-risk group and they need interventions and close monitoring in pregnancy. Now, this chart compares the WHO focused antenatal care model with the revised 2016 WHO antenatal care model. The first visit in the first trimester, they all come once. The first one in the original focused antenatal care model by WHO takes place anytime between 8 and 12 weeks. And the second one between 24 and 26 weeks. The third visit takes place at 32 weeks. And the fourth visit between 36 and 38 weeks. However, in the revised WHO antenatal care model, the first contact can be anytime, up to 12 weeks. In the second trimester, there are 2 contacts. The first contact takes place at 20 weeks, and that is when a lot of women are also screened for some medical disorders like hypertension in pregnancy, diabetes in pregnancy. The second contact, which is contact 3 under the 2016 revised WHO model, takes place at about 26 weeks. Then in the third trimester, in the original WHO focused antenatal care model, there are 2 visits. The first one at 32 weeks and the second one between 36 to 38 weeks. In the 2016 revised model, we have 5 contacts. The first one takes place at about 30 weeks, second one 34 weeks, the third one at 36 weeks, the fourth 38 weeks, and the last one at about 40 weeks. However, irrespective of what happens, the woman must return at 41 weeks if the woman has not given birth by then. So this chart illustrates the various events and activities that takes place in the focused antenatal care program. For example, in the first visit, The first thing that is important is that we must categorize the pregnant woman into either high risk or a low risk antenatal patient. Then we want to determine the gestational age. Then the basic parameters are taken, like the blood pressure, the weight, the height. Then some routine investigations will take place, like urine analysis. You want to determine the blood group. You want to determine the hemoglobin concentration. Then you want to give the first tetanus toxoid immunization. Then you also want to commence iron supplementation, and we also want to take adequate history, which will be taken and properly documented in the antenatal card. The second visit takes place at 28 weeks. The major activities that take place at 28 weeks include clinical examination. You want to rule out anemia. Yes, fine. When the patient came the first time, the patient was placed on routine hematinics, iron supplementation. You want to examine that there is no anemia. You also want to ensure that the symphysiofundal height is compatible with the patient's gestational age. You also want to examine the fetal heartbeat to be sure that it is regular within normal limits. You also want to check the blood pressure, the weight. You also want to look at the weight. You do a urinalysis to rule out preeclampsia. You also want to continue your iron supplementation, and all of these activities too must be properly documented in the antenatal card. At 32 weeks, which is the third visit under the focused antenatal care program, what do? You also check the hemoglobin concentration. You want to give the second dose of tetanus toxoid immunization, and you want to start giving out instructions on the birth plan. And you also want to give recommendations for lactation, contraception, and everything at each visit must be properly documented in the routine antenatal card that is personalized to the patient. Then at 36 weeks, that is when you need to sit down with the pregnant woman. You need to plan a delivery. So you need to examine the woman too for fetal presentation. You want to ensure that the presentation is normal. And you also discuss, the various things that would happen about the time of labor. And all of these activities must be properly documented also in the antenatal care, in the antenatal card. Now, I will now expatiate further on these various activities. What do you do at each visit? At the initial visit, you need to take a detailed evaluation through three major things. One, adequate history. History is very important. You also want to examine the woman, and you also want to do some laboratory workup. All these three things will be further discussed as we go on. So based on the results obtained at the initial visit, further workup and a program of care will be planned on individual basis. And maternal or fetal factors that may require special care for specific mother are identified and also noted. In the subsequent visits, this will be based on the plans made at the initial visit. And newly developing situations during follow-up are also noted, and management plans are modified accordingly, particularly if along the line you discover that a patient that you have scheduled for routine antenatal visit now develops a serious medical condition like preeclampsia, gestational diabetes, development of varicose veins, and some other conditions that may jeopardize the outcome of the pregnancy. Then they may need to be rescheduled to be coming more frequently so that they can be closely monitored. The history, what are the important history that you need to take when this woman comes? You will need to take history about the present pregnancy. You need to accurately date the gestational age. You need to ask for when the woman saw her menses last, the last menstrual period, which is the first day of the last menses that the woman saw last. So it is important you document that. And based on that, you will now calculate the gestational age and determine, the expected date of delivery. Now, you also take history on any symptoms which may be major or minor complaints that the woman may have. Some of them will come and they tell you they have vomiting, they have nausea, they are not able to eat, they have a history of indigestion, all manner of complaints they will come. These complaints need to be properly, taken and documented and addressed, when they come. And that is why we talked about physiological changes in pregnancy. And if you will recollect, we talked about that we said that most of the complaints that these women have is because of the physiological changes occasioned by the hormones that accompany pregnancy. So it will be an opportunity, for the doctor that is seeing them to actually tell them why some of those symptoms are present in them, and which will also allay their fears. You also want to document, depending on when they are coming for the first time, you also want to find out if the woman actually has started perceiving fetal movement. Generally, you expect that primigravida should start at least by 18 to 20 weeks. Most of them are expected, to have started perceiving fetal movement. And in people who have delivered before in multigravida, you expect that as early as 16 weeks, they can actually start perceiving fetal movement. You also have to document history of any of the danger signs that may be present. Some of them have chronic hypertension. Even at presentation at the initial visit, the blood pressure is markedly elevated and all that. So they will even tell you that they are hypertensive, they are diabetic and all that. You need to take past obstetric history too. Details of any obstetric complications in previous pregnancies, previous history of stillbirth, previous history of antepartum hemorrhage, previous history of preterm delivery, previous history of IUFD. All these are history that must be taken when they present the very first time. Then you need to take important family history. Is there any family medical condition in them? Some people have family history of hypertension. Some people have family history of diabetes. These are important family history. There could be, some of them even have sickle cell patients in the family. These are important history that needs to be taken and properly documented when they come, the first time. History of congenital, previous history of congenital anomalies, multifetal gestation, hypertensive disorders, all these are very, very important. Then apart from family history, even personal history. Some patients, even already, they know that they have some medical conditions. Some of them will come and say that they are asthmatic. Some of them will say, well, I have a peptic ulcer disease. Some of them will say I'm hypertensive. Some of them are even already on treatment for diabetes and all that. So all these are personal history that must be properly documented, when they come the very first time. Then you need to take history of smoking, history of alcohol, habitual drug use. These are all important history that must also be taken the very first time when they come, for antenatal care. Now, examination. It is very important when they come the first time to do the vital signs. Vital signs is very important. You need to take the height, you need to check the weight, and this must be properly documented because all this would also assist in categorizing into whether high risk or low risk. And we also form the basis towards advising nutritionally. Some of them need to cut down on some calories in pregnancy, But if you are not taking the weight, if you are not doing the height, it may be difficult actually, to give adequate advice to these women. Then detailed physical examination for medical or surgical illnesses is very important. We should examine from head to toe in pregnancy. Why we pay special attention to the abdomen. Abdominal examination, objectives of that is actually to determine the fundal height. And the fundal height, we measure from the symphysis pubis up to the height of the fundus. That gives an estimate. It also helps to estimate the gestational age of the patient, plus or minus by 2 weeks. Then, after 10 weeks, it is expected that the Doppler machine should be able to pick, the fetal heart tones. However, with the routine fetal stethoscopes, you should be able to pick the fetal heart tone from above 20 weeks in some women. However, women who are obese and who have thick abdominal muscles or fat, it may be a little bit longer, like 24 to 26 weeks, before you are able to pick the fetal heart tone with the routine peanut stethoscope. Then, also, fetal presentation must be done, after 28 weeks. And particular malpresentation must be taken note of after 34 weeks. And such patients need to be closely monitored in order to plan delivery if the malpresentation still remains persistent by the time the woman is at term. Now, also at the initial visit, we may want to do pelvic examination. And some of these are not routinely done nowadays. In those days, you may want to use it to determine the gestational age, particularly if the gestational age is less than 12 weeks. So actually, you may need do a bimanual examination to determine, the size of the uterus. Then you may also want to palpate the agnesia, for abnormality. Some women will have coexisting, some women will have ovarian cysts coexisting with pregnancy and all that. It's also an opportunity to screen women for cervical cancer. So pap smear may also be done for these women when they come, Then early evidence of pregnancy on physical examination, like cervical softening, the Chadwick sign, which is bluish coloration of the vagina and the cervix, von Braun-Feinwald sign too, which is irregular softening and enlargement of the uterine fundus. Although these are not signs that we routinely look for now these days. Then the Hegar signs, which is a non-sensitive indication of pregnancy, and even the absence does not actually exclude pregnancy. Now, what are the various diagnostic workup that we need to do during normal antenatal care? We have talked about hemoglobin estimation. It is very important. The very first day the patient comes, we must determine the hemoglobin level. It is done at the initial visit. Then you want to repeat it between 28 and 32 weeks. And by the time the woman is at term 2, you also want to estimate the hemoglobin concentration. Then it is important also to know the blood group and the rhesus typing of the woman. And that is done at the initial visit. Then you also want to screen for syphilis. You do urinalysis. Urinalysis should actually be done at each visit to detect the presence of proteinuria. If you recollect, when we were talking about renal changes that take place in pregnancy, we said that the urinary protein excretion should remain, it doesn't change in pregnancy. You shouldn't have protein in the urine in pregnancy. So presence of protein in urine needs to be properly investigated to rule out preeclampsia. So, and that is why it is important at each visit, urinalysis should be done. Then, urine culture and sensitivity may also be done during the initial visit to detect asymptomatic bacteriuria. Some of them have asymptomatic bacteriuria, which may also predispose them to anemia in pregnancy, and it may also even cause abortion, spontaneous abortion. It may also cause recurrent urinary tract infection in pregnancy. It may cause preterm delivery and all that. And that is why it's also recommended, at the initial visit. Then for people who are rhesus negative, indirect Coombs test, we may also need to do it. And this may also be repeated, subsequently in pregnancy at 28 weeks, at 34 weeks, just to be sure that there is no sensitization, particularly if the husband of the patient is a rhesus positive person. Then routine ultrasound is also done at the initial visit, also to date the pregnancy. Then an anomaly scan is done, usually between 18 and 22 weeks, also to rule out gross fetal abnormalities. Pap smear, we talked about it. These are things that, should also be done. It's also an opportunity for some of these women, to be screened for cervical cancer. That may be the only opportunity they will come to the hospital, and we should use the opportunity to actually screen them for that. Then we screen for hepatitis B surface antigen, retroviral screening. All these are tests that are done, at the initial visit. The retroviral screening is actually done. Some of these serology tests is better, the patients are adequately counseled, prepared before the screening is done, so that in case they are positive, managing them will be easy if they have been adequately counseled before the serology tests take place. And then this is just a summary of what I just talked about, the important investigations that we need to do and when we need to do them, and what are the reference ranges, that is important, and what are that are important to allay the fear of both the woman and even the obstetrician of any problem. Now, in subsequent visits, it is still also very important to take history. Anytime the patient comes, you want to take history. You want to know how the pregnancy is going on. You want to know if there are new developments in terms of maybe new symptoms and all that. And also, you also want to follow up on previous complaints. Some of them might have complained about one thing or the other that you have instituted management upon. You want to know if the symptoms are ameliorating or if the symptoms are actually getting worse. So it's also very important to follow up on such complaints. Then, between the last time you saw the patient and even now, you also want to find out if there are new complaints, so that those complaints can actually be addressed. And also, in the process of taking that history, you want to identify the development of any other danger signs or danger symptoms. Then you also want to find out from the woman, how the woman is interacting with her baby vis-a-vis the fetal movement history. The woman will tell you, okay, do you feel your fetal movement? How often do you feel it? And all that. So it's also very important to do that, even during follow-up visits. Physical examination, it should be a brief, detailed examination, including the vital signs, the anthropometry, and general examination. Some of these things we talked about in the previous slides. You want to take, the pulse rate, the blood pressure, the respiratory rate, because any of them may be pointers to danger signs in pregnancy. And that is why at any time these women come for routine antenatal clinic, we must examine them, along this line. Then we must also ensure adequacy of weight gain during the last visit, which may be a pointer even to some medical conditions. A woman that has gained excessive weight beyond what is expected. It is expected that in pregnancy, most women will gain about half a kilo, 0.5 kilogram in about a month. So by the time you are having an excessive weight gain, it could be a pointer, to edema, it could be a pointer to polyhydramnios, it could be a pointer to so many other things that may warrant you, looking closely, investigating, and monitoring them very well so that you can have a very good outcome, a very good pregnancy outcome. The adequacy of fundal growth since last visit, it must be compatible with the gestational age. I mentioned earlier that the fundal height, is plus or minus 2 weeks the gestational age of the patient. When you measure from the pubic symphysis to the fundal height, is usually plus or minus 2 weeks. So if it is outside the range, which could be above or below, then you want to check what may be responsible for that, either large for date or small for date. Is it IUGR we are talking about or what? So, but if you don't examine to determine the fundal height, the pseudofundal height, you may be able to pick, some danger signs also in pregnancy. The presence of fetal heartbeat. This is very important, particularly when at every visit, you must listen to the fetal heartbeat to know the pattern and also to be sure that it is also regular. Then, presence of other findings such as generalized edema. Generalized edema, we also need, to look closely for that. Some of them, all you need to do is just to reassure them that, a woman that has generalized edema, the blood pressure is normal, there is no protein in her urine. All you need to do is just to reassure her, this is just physiological edema. All she needs to do is to elevate feet anytime she sits down or she lies down, and she should avoid sitting down for too long, that, with time, some of the edema actually tend to resolve. Now, how do you assure the woman that a fetus is okay, during antenatal care? Now, and this brings us to assurance of fetal well-being at antenatal, during routine antenatal care. When you have a progressive increase in maternal weight that is compatible with gestational age, progressive fundal height growth as per expectations, it reassures that the pregnancy is progressing normally. It reassures that the baby is growing optimally. Then, when the woman also tells you of adequate perception of fetal movement, by the time a woman tells you that she's able to perceive about 10 movements within 12 hours, it is also reassuring that, okay, the fetus is doing very well. Then, also, however, when you have an abnormality, you may need to carry out some investigations to be sure that the baby is actually doing well. And if the baby is not doing well, you may need to also determine when intervention should take place. Some of these tests include non-stress tests, contraction stress tests, fetal biophysical profile score. You may also need to do Doppler ultrasound velocimetry. It's also very important. And you may need to do invasive ultrasonic fetal scans for some abnormalities. So these are very important things that you may need to do to reassure the woman that, okay, the baby is doing fine, and also to reassure yourself as obstetrician that the pregnancy is also progressing adequately. There are some screening that needs to be done too during routine antenatal care, particularly if there is a family history of congenital anomalies. We may need to do some tests to rule out the common anomalies that we have, like Down syndrome. We need to do a nuchal translucency scan, which is performed at the end of the first trimester at about 13 weeks. If it is increased more than 6 millimeters, then we need to watch closely. We may be dealing with a fetus with a Down syndrome, particularly if the history is there. We need to do a combined test. We need to do a triple or quadruple test, which is done between 15 to 20 weeks. And the combined tests include the increased nuchal translucency, the increased beta ACG, then the Papa test too. All these tests can be done between 11 to about 14 weeks, to rule out presence of Down syndrome. Then I mentioned earlier too that anomaly scan too, should also be done, particularly if there is family history or previous history of congenital anomaly in the woman. So, and this is done between 18 and 22 weeks. Triple marker test, also this is performed between 15th and 18th week, and this includes the alpha-fetoprotein, ACG, and estriol. When you have a high alpha-fetoprotein levels, it suggests neural tube defects, anencephaly, and even it may be a wrong date. But when you have a patient that has a low alpha-fetoprotein and estriol and high HCG, you have to think about trisomy 21, that is Down syndrome, or trisomy 18 heteros, or any other type of chromosomal abnormality. Now, this slide talks about the quadruple test, and this may be essential, particularly for patients registering very late with a past history or family history of congenital anomalies, and the tests that are done are also listed on the slide. Now, the 8 interventions that we carry out during routine antenatal clinic, this includes health education. When these women come for routine antenatal clinic, usually the midwife gives talk on various topics that will help in ensuring the best pregnancy outcome. And these topics range from things on nutrition, to hygiene, to personal hygiene, nutrition. It talks about malaria prevention in pregnancy. It talks about birth preparedness. It talks about, prompt reporting of danger signs of pregnancy. Even dressing. Some women do not dress appropriately in pregnancy. So these are some of the topics that are addressed, during routine antenatal clinic. They talked about wearing of low shoes, the wearing of properly fitted clothing and all that. And of course, I also talked about labor and delivery. It is during routine antenatal clinic sessions that all information about labor, information about delivery are given to all these pregnant women, and they also have opportunities to ask questions, that may be broadening their mind or on what they have experienced before, during these routine antenatal clinic sessions. Also, basics of family planning, child rearing, and immunization are also discussed, during routine antenatal clinic session. We also ensure that there is iron supplementation, and psychologically too, these women are prepared, for labor, delivery, and even the care of the child when the child is delivered. So these are all interventions, that take place during routine antenatal clinic sessions. Now, risk assessment in pregnancy, we have talked about it, and it is actually carried out taking into consideration the previous obstetrics, the previous medical, the previous surgical, the previous psychological, and the social history. And this is done not only at the initial visit, it is a continuous process, because at any given point in time, there may be a risk, we may have development of risk during pregnancy, labor, and even delivery. So it is carried out on all pregnant women at each antenatal clinic, and this is based on patients' complaints, their clinical examination. And patients with underlying health conditions are closely monitored to pick danger signs at the earliest time possible. Now, who are these women with underlying health conditions? Or which women do we regard as high-risk pregnant women? These are women with bad obstetric history, which could include previous history of recurrent miscarriages, previous history of preterm deliveries, previous history of intrauterine fetal death, previous history of poorly controlled medical condition in pregnancy, like heart disease, hypertension or preeclampsia, which could be essential, it could be renal, or even pregnancy-induced hypertension. Women with diabetes, which could be insulin-dependent diabetes mellitus or non-insulin-dependent diabetes mellitus. Even women who had gestational diabetes in previous pregnancy. So these are high-risk women. Women who, even when they present at the initial visit with severe anemia, women with twins, triplets, or higher order gestation, women with previous history of placental abruption, women with preterm labor, women with hemolytic anemia, thrombocytopenia or megaloblastic anemia, or women with bleeding disorders women with previous history of deep vein thrombosis. All these are categorized as what? As high-risk pregnant women. And they are monitored very closely. Also, we may have women with neurological diseases, women with epilepsy, women with brain tumor, or women who are on treatments for any form of malignancy, like cervical malignancy, ovarian, breast. All these women constitute high-risk pregnant women. Women with antiphospholipid syndrome, women with cervical incompetence, which will have even manifested as recurrent pregnancy losses. Then women with fibroid coexisting with pregnancy, particularly large fibroids, and particularly fibroids even located within the lower uterine segment. So these are all women with high-risk pregnancies, and women with fetus with congenital anomalies. All these. Previous cesarean section, yes, it's also very, these are women that when they come, we categorize them as high-risk pregnant women, and they also need, to be monitored as such. The pregnancy needs to be closely monitored to determine danger signs that may affect the outcome of the pregnancy at any given point in time. Some of the other conditions too that we also need to take note include previous history of delivery of large babies, with particularly previous history of shoulder dystocia, previous history of retained placenta, previous history of inversion of uterus, previous ruptured uterus. Some of them might have had prolonged obstructed labor that might have resulted in a ruptured uterus, and some of them may be lucky for the uterus to have been repaired, and now they are coming in pregnancy. These are women that need to be closely monitored because they are high-risk pregnant, or women who have had extensive perineal tears, 3rd degrees, 4th degrees perineal tears. These are women that we also need, to monitor very closely in pregnancy. So, today we have talked about several physiological changes that take place in pregnancy. We talked about the antenatal care, the focused and the traditional one, and we have also mentioned some conditions in pregnancy that we need to monitor closely, and this is that is high-risk pregnancy. How we will monitor them to ensure that the woman and her baby are fine at the end of the day. The overall aim of antenatal care is actually to ensure the birth of a healthy child to a healthy and happy mother. I want to thank you for listening, and I believe that this lecture has helped us to know what we understand by normal pregnancy, the physiological changes that we have, and the various models of antenatal care in pregnancy. Thank you very much for listening.